Okay, so let's get started. Today we are going to discuss the lens surgery. So you can consider today's lecture like a mini phacoemulsification condensed course. So we are going to go through the pre-operative steps that we have to do before the cataract surgery. Specifically, we are talking about the phacoemulsification. And then what are the steps of phacoemulsification surgery, and what are the intraoperative and postoperative complications of cataract surgery. So starting first with the preoperative steps, so we start our evaluation of a patient with cataract surgery by operative steps or by history. So you analyze the patient's complaint, analyze the patient's problem. So we know that the cataract will cause gradual progressive diminution of vision in most of occasions. But for some occasions, it will cause pain, like in patients with having phacomorphic glaucoma or phacolytic glaucoma, as we mentioned the last time. Also, sometimes it can be acute instead of being progressive, such as in cases of trauma. So this should be taken into consideration. After the complaint, we analyze the patient past ophthalmic history. So when you are proceeding to the future, don't forget about the past. Ask about the past history of a patient, like what will be the in history of trauma, it can cause the cataract. In history of any intravitreal injections, this will indicate that the patient has maybe diabetic retinopathy, and this cataract surgery may aggravate the diabetes or diabetic retinopathy. Also, you should inquire about the history of previous other eye surgery, as this can be like complicated, so you may anticipate that it could be some complications that could happen to this eye as well. Then you should proceed for the medical history. For example, diabetes, hypertension, ischemic heart, and any other systemic problems that the patient is suffering from. Also, chronic COPD or chronic obstructive pulmonary diseases will make the patient unable to lie down, so this also should be inquired. The drug history, like the aspirin, although that the cataract surgery is considered a bloodless surgery, but also you should inquire about any anticoagulants that the patient is taking. But what is very important to ask about, if a male patient is taking a tamsuline. A tamsuline is a drug, is an alpha blocker used for benign prostatic hyperplasia. So those patients who have benign prostatic hyperplasia, they are on tamsuline. They could be at risk of what's called IPHIS, or intrapupillary floppy iris syndrome. We are going to go through this later on. So this is important to not to miss the tamsuline and the anticoagulants. Also, if the patient has any allergy to any drug, this should be also noted. After history, you proceed with examination. So you measure the patient's visual acuity to know what will be the uncorrected and best corrected visual acuity, what will be the potential vision that this patient could develop after the surgery, if he has amblyopia or not. Accurate refraction. Also, sometimes those patients could have a significant refractive error, so this should be counseled, especially if they are having astigmatism. So if you are going to plan for toric intraocular lens, which will correct both the spherical error and the cylinder, this also should be put into consideration in the planning of the procedure. Also, this will be important for planning the incision site, as we are going to mention right now. Pupil examination, as usual, to check if the patient has any relative afferent pupillary defect, which you can denote that this patient could have a problem in the posterior segment or a problem in the afferent visual pathway. And it is very common scenario that you see patient with mature cataract or totally white cataract, and the patient has a visual acuity of hand motion, and you think that the problem is in the cataract, so you proceed to the cataract surgery. But if you just did this simple test of pupil examination, you may find relative afferent pupillary defect. So the next step is you do ultrasound. You will find a big retinal detachment behind. So pupil examination can give you a clue about what is behind the anterior segment. External examination as well, you need to check for any problems in the ocular surface, any infection like this infected chalazion, which you can put the patient at risk of developing endophthalmitis. Intraocular pressure measurement also should be a part of routine assessment preoperative to check if the patient has high intraocular pressure or not. Because if the patient has high intraocular pressure and you open the globe, this will be put the patient at risk of choroidal detachment. Sudden decompression of the eye can lead to choroidal detachment. So this you need to control the intraocular pressure if it is very high before the operation. Assessments of the eyelids also is a part of the routine examination. If the patient has this intraocular cases with rubbing lashes against the cornea, this could also put the patient at risk of endophthalmitis. The same as the lacrimal system, positive regurg test also should be done, because if the patient has positive regurg, then this means that they have nasolacrimal duct obstruction, which also put them at risk of endophthalmitis. Conjunctiva also should be examined for the presence of conjunctivitis, again, a risk of endophthalmitis. Enophthalmic socket, if the patient has the other eye has enophthalmic socket, this also should be checked for the development of endophthalmitis. The orbit should be also assessed. If the patient has this deep-seated orbit or these high prominent supraorbital ridges, this can put the patient at a specific risks during intraoperatively, like this mid-detachment. So there will be difficulty in manipulations intraoperative. So this will make what we do is what's called risk stratification. So this patient could be at higher risk than average patients. Then you proceed for the corneal examination. So this is one of the important things not to be missed is the corneal guttates or corneal guttata. So those patients who have this corneal endothelial dystrophy, this can result in post-operative corneal edema due to corneal decompensation if this corneal guttates was missed before the surgery. So if it is present, those patients should be counseled. We need to do pachymetry. We need to do endothelial cell count so that we are making sure that the ultrasound of the phaco machine will not harm the endothelium. We will discuss the endothelial dystrophies in the pathology lecture, so this will be coming later on. The anterior chamber, you should also check for the presence of any cells or flare in the anterior chamber, which will denote the presence of uveitis. So this eye which has active inflammation shouldn't be operated upon, which is during acute inflammation. So those patients should first need to be controlled medically to control this uveitis, and then we proceed with the surgery. Also, the iris has very important sign that shouldn't be missed, which is the iris neovascularization. You see, this is iris neovascularization, which means that the patient has ischemic process like proliferative diabetic retinopathy or ischemic vein occlusion or ocular ischemic syndrome. So those patients may require further management, like they can need PRP or pan-retinal photocoagulation or anti-VEGF injection intraoperatively to prevent the progression of the ischemia, because the lens or the cataract extraction itself it can be a cause of progression of the ischemic process, because the lens secrete VEGF or secrete the anti-VEGF, and when you are removing the lens, it will just remove the natural anti-VEGF present from the lens. So this should be also important for counseling of those patients. Anterior, the lens also should be checked for a very important disease, which is called pseudoexfoliation. Pseudoexfoliation, there is a dandruff-like material present at the anterior lens capsule, and this is again put a specific risk during surgery, like small pupil, like zonial dialysis, like the high incidence of post-operative phimosis or post-operative IOL dislocation. So this is also should be mentioned and checked for before the surgery. The last thing to check, this is how does it look, the pseudoexfoliation when it is a small pupil. You see this whitish material, this is the pseudoexfoliative material, and also it has a risk of developing a secondary open-angle glaucoma. We will come to this later on in the glaucoma lecture. In the anterior hyaloid, you can see that this is the last thing that you can see with normal slit lamp examination. So you can see the presence of cells present here in the anterior hyaloid, which denotes that this is called the Schaffer sign, or the presence of Schaffer sign can be denoting the presence of retinal detachment. So these cells are basically retinal pigment epithelial cells, or these cells can be whitish cells due to just uveitis. So those patients could have intermediate uveitis or cyclitis. So this is, again, we need to know what is the nature of these cells so we can manage accordingly. Then after that, you check the fundus. So first of all, you check the vitreous. So what you can find that you will see fundus is hazy with this reddish appearance. This is a patient with vitreous hemorrhage. So in this case, mostly you are going to refer the patient for a vitreoretinal surgeon. Also, you may check the fundus for the presence of PVD, which is this floating ring in front of the optic disc. This is the detached posterior hyaloid, and this has mean that those patients could experience floaters, and this is also should be counseled to the patients that those patients could have floaters post-operative, even if they are not appreciating it pre-operative, as you are removing the lens opacity. Also, you check the fundus for the presence of any breaks in the retinal detachment, and this means that this patient should be managed by the vitreoretinal surgeon, or the presence of optic atrophy, which means that this patient will not benefit from the cataract surgery most likely. If you have hazy fundus view, or you cannot appreciate any fundus details, so you would order as a preoperative assessment, order ocular ultrasound to check for the anatomical location of the retina, whether it is displaced, or it is detached, or it is in place. After that, you will do biometry, which is simply the IOL calculation. So after doing the assessment, the preoperative assessment, history and examination and investigations like ocular ultrasound if needed, then you proceed with IOL power calculation, which is called the biometry. After that, after the examination, you do the surgical plan. So the surgical plan includes the IOL type and the power. So you know whether you are going to implant a single piece or multi-piece intraocular lens, depending whether it is primary or secondary surgery. Also, if you are going to implant a hydrophilic or hydrophobic, and what is the power depending on the biometry. Also, you would know what will be the incision site. So the incision site will control some sort of correction of astigmatism. Like if you have a steep meridian, so you can make the incision site at this steep meridian, which will cause some flattening, correcting like around 1 to 1.5 diopters of astigmatism. Also, whether you are going to do the surgical procedure from superior approach or from temporal approach, depending also if the patient has a very narrow orbit and you need to more space, so you may go through lateral approach. Type of anesthesia, also you should mention it before the surgery. So if the patient has any risk for topical or for local anesthesia, you may plan for topical anesthesia or general anesthesia. So depending on the experience of the surgeon and depending on the patient's general condition. Special risk, which is the risk stratification, you should mention if the patient has any problem that like it can cause the patient any increase in risk during intraoperatively or postoperatively, like what we mentioned, like pseudoexfoliation, like white cataract, like small pupil, like the presence of any corneal opacities. So this can lead to some certain risks during the surgery that makes that this surgery shouldn't be your first surgery, but it will be for more experienced surgeons. Okay, so this will be the intraocular lens type, and this will be how would we plan this incision, whether it is superior or temporal. This is how would we plan the type of anesthesia and specific risk. Like this patient has multiple risks. This patient has small pupil, has white cataract, has also this sunken eye or this prominent supraorbital ridge, making the manipulation more difficult. So this also should be noted before the surgery. After that, you will proceed with the IOL power. IOL power is the process which is called biometry. biometry is how would we measure the intraocular lens power. And for measuring the intraocular lens power, we have two main factors or two main components. The first one is called the axial length, which is basically the length of the eye, which is measured by A-scan ultrasound or laser interferometry devices, such as the IOL Master. The second parameter is called the corneal central curvature. The central corneal curvature is measured by a device called keratometry, as we know from the basic optics, or the corneal topography. This is the main two components for all formulas, but for some other formulas, for some intraocular lens formulas, they can use other parameters like white-to-white measurement for corneal diameter, like what happens, for example, for the implantable or phakic intraocular lenses, they use also the white-to-white measurement. And for other formulas, we need the anterior chamber depth, like Holiday formulas. They also use the anterior chamber depth beside other factors. So the basic formula is called the SRK formula, like the power of the lens equal A constant minus 0.9 multiplied by the average K reading minus 2.5 multiplied by the axial length. So this will be like the formula, one of the early generations of formulas. So I just brought it to you to know what is the relation between different variables. So here you can see that one diopter, consider this 0.9 like one diopter. So if there is increase or decrease in the K reading by one diopter, this will equal the difference in the one diopter of IOL power. But here, the more significant factor will be the axial length because it is multiplied by 2.5. So if you are measuring the axial length, like here, from the cornea to the eye, to the lens, to the vitreous, to the retina, you will get, if there is any 1 millimeter error of axial length, this will result in 2.5 diopters of IOL power error. So this is very crucial to have an accurate estimate of the axial length. If a patient has longer axial myopia, or longer axial length, meaning that he is more myope, this will mean that he will be having low power IOL. So if like a patient has axial length of like around 30 millimeter, you expect that the power of the IOL will be around 4 to 5 diopters in this range. And if the patient has short axial length or hyperopia, this means that we need high power intraocular lens to compensate for this refractive shift or this hyperopic shift. So we need, like, for larger intraocular lens, like 28, 30, if the patient has a high hypermetropia. The more the hypermetropia, the more the intraocular lens power. Okay, so this is the relation between the different variables. How do we measure the axial length? We said that with axial length will be the most important factor to determine the refractive power of the intraocular lens. It can be measured by several methods, including the contact ultrasound. The contact ultrasound, it will be the easiest, but it will be the least accurate, because you are indenting the anterior surface of the cornea, causing hyperopic shift. So this will result in overestimation of the IOL power. So if you are just indenting the cornea by even 1 millimeter, this will result in 2.5 diopters of increasing the IOL power. So this is very important that you do. If you are going to do this, you do it under the slit lamp to check exactly where you are, and if you are doing indentation to the cornea or not. Another method, it's called the emergent ultrasound. The emergent ultrasound, we just put the ultrasound probe within a cup filled with saline. So this will minimize, there will be no touch between the probe and the cornea, as you can see here. So it will be more accurate. So the standard deviation of error can be only 0.1 millimeter increasing or decreasing. The most accurate is the devices based on the laser interferometry principle. such as the IOL master. So they will have the most accuracy. But the problem with or the disadvantage of laser interferometry devices that they are based on laser waves, and you see or laser beams. So as you know, the laser will not pass through a dense opacity. So if those patients have mature cataract or white cataract, they will be unlikely to be calculated, or the axial length will be unlikely to be calculated with this method. So they will need the conventional method using the A-scan or the ultrasound. Okay, so this is for the how would we measure the axial length. Regarding the different formulas and which these formulas are using for, so we have different formulas depending on the axial length. So the Hoover Q is used for patients who have hypermetropia, like short axial length, where the eye is less than 22 millimeter. SRKT, remember T for tall, so T is for patients who have long axial length more than 26 millimeter. Holiday 1 is standard for patients who are having axial length between 22 to 26. So this will be like the average for most of people. Higgs L is used for the patients who underwent previous refractive surgery. Higgs and Holiday 2 is taking into consideration the preoperative anterior chamber depth. This was asked specifically in the exams before. So remember the Higgs and Holiday 2, the one of the parameters that is checked is incorporated into these formulas are the preoperative anterior chamber depth and other factors. Okay. So when should you go suspicious for the IOL power or during the biometry? Where should you have high index of suspicion regarding the axial length or keratometry? First of all, if you found extremes in the axial length, or either it is short, extra short, or extra long. So if you have a patient who have extra short, like less than 20 millimeter, well, if you are doing contact biometry, you may be doing more indentation. Or if the patient has high axial length more than 25 millimeter, well, if this patient could have myopia, so you maybe do ultrasound on the staphylomatous part. Difference between more than 0.3 millimeters between eyes not corrected by refraction. Or if there is poor waveforms, as you can, let me show you these poor waveforms. So you see this is the waveforms of the A-scan. When you are putting the A-scan probe perpendicular over the surface of the cornea, there should be spikes, giving spikes. These spikes should be at parallel plane, depending on your position. So if these spikes have the same level, then this means that you are perpendicular over the globe. If these spikes representing the anterior and posterior corneal surface, the anterior and posterior lens surface, and then the retinal surface are not on the same level, so you expect that you could be not perpendicular on the surface of the globe. So you should adjust your position again. So poor waveforms also should be checked in the biometry report. Regarding the keratometry, so if the patient has also extremes of K readings, like if they have flat K readings less than 40 or steep K readings more than 47, this should be also raise an index of suspicion. Average case difference more than one diopter between eyes. So this also should be make you repeat your biometry if you find great difference between both eyes. Patients with any previous refractive surgery, so those patients will not be candidates for conventional biometry. Those patients will need online calculators like by the Askers in order to have more accurate calculation of the IOL power. Difficult patients cooperation. and the K readings are significantly different from the refraction. So you know the K readings is the difference between the K1 and the K2 will indicate the astigmatism. So if you find that the patient has like glasses of -3 and you have the K readings like 46 and 40, so there is like 6 diopters difference in between the K readings, while this is not explained by the patient's refraction. So this is again, you need to review and recheck your measurements. After you measure the IOL power, now you need to know what will be the IOL itself that you are going to choose. So IOL selection should have also some factors to put into consideration. So these factors like the materials and designs that you need to, first of all, you need to put materials that will be causing low or the least intraocular inflammation as possible. You want to put like inner substance. Also, the material and the design of the material should be easy in handling, like it will be showing easy unfolding, easy implantation. And also in special cases where there is insufficient capsular support, if you are having a patient with myopia or history of uveitis or a patient with pseudoexfoliation, you may also, the IOL choice may be a little bit different from the conventional cases. Also, if the patient has corneal astigmatism, or having high order aberrations, specific IOL may be indicated. So this will be maybe beyond the scope of this lecture, but for what is needed really for the exams is that we have certain precautions in the materials and certain precautions in the design that will minimize the incidence of posterior capsular opacification. As we are going to mention at the end of the lecture, the posterior capsular opacification is the commonest complications of uncomplicated cataract surgery. In order to minimize this incidence of PCO, there are certain factors. These are frequently asked in the exams. These factors depend on the material and depend on the design. So what are the different materials that we can use it for IOL manufacturing? It will be the polymethyl methacrylate, the silicone, the acrylic hydrophilic, and the acrylic hydrophobic. So in order of frequency of PCO, the acrylic hydrophobic will be the least incidence of PCO, followed by the acrylic hydrophilic, followed by the silicone, and the highest incidence of PCO was found with polymethyl methacrylate lenses, which are the hard lenses. Okay, so remember this for the exam. This is very important. Acrylic hydrophobic, followed by acrylic hydrophilic, then followed by the silicone and the polymethyl methacrylate. Regarding the design itself, it can also play an important role in preventing the PCO. So for the design, we have some intraocular lenses with round edges and the others with square edges. So which one will be better to prevent the PCO? It was found that those patients who have this square edges, this square edge of the intraocular lens will be useful for minimizing the PCO. So if you want the best lens that will minimize the incidence of PCO, it will be the hydrophobic acrylic intraocular lens with a square edge. Another thing also is called the barrier effect. So basically, the PCO was or occurs due to migration of the lens epithelial cells. So if you have like remnant lens epithelial cells after irrigation, aspiration, or polishing with the capsule, these lens epithelial cells will be remaining in the capsular bag, and it will cause development of the PCO. So how can we prevent? We can prevent that by, as we mentioned, by the intraocular lens, and also by during the capsulorhexis, as we are going to discuss later on. The intraoperatively, we are making the capsular opening slightly smaller than the optic of the IOL. This is called the optic of the IOL, and you can see this is the edges of the anterior capsular opening, which is the anterior rhexis. So by making the anterior axis is slightly smaller than the optic, this will result in barrier effect. So there will be like some sort of adhesion between the anterior lens capsule and this very thin or very minimal edge of the anterior capsule. This will result in my prevention of to prevent the migration of the equatorial lens epithelial cells to the posterior capsule, and this will minimize the incidence of the PCO. So this is also asked before in the exams. So the sorry, I said that the adhesion between the lens and the posterior, the lens and the anterior, this is the adhesion between the lens and posterior. So this is the adhesion of the intraocular lens to the posterior capsule. This is what will minimize the lens epithelial cells migration by just making the lens tight to the posterior capsule. Now, after we measured our intraocular lens power, now we are ready for the surgery. So the surgery, as any surgery, starts by anesthesia. What are the different types of anesthesia that could be utilized in cataract surgery? It could be topical. So topical has an advantage and disadvantage. Advantage is that it will minimize or prevent the complications of anesthesia. So any kind of anesthesia has its complications, but the one which will be without complications, it will be the topical. But the disadvantage is that the patient will have full sensation, it will have anesthesia, but not akinesia. The patient will still be able to move his eyes. So this can, if the surgeon is not experienced enough, this could put the patient's surgery at risk. Also, the problem is that it will be not useful for lengthy procedures. So if the patient underwent any complications, topical anesthesia will not be enough for this case. Another method, which is called the subtenon anesthesia. In the subtenon anesthesia, it will provide longer anesthesia, so it will anesthetize the ciliary nerves present at the optic nerve, present around the optic nerve. So passing a cannula called the subtenon cannula into the subtenon space and injecting anesthetic agents, it will anesthetize the eye, providing more comfort during the surgery for longer duration. We use it particularly for patients who have high risk of perforation of the globe during preoperatively, especially those patients who have high myopia or large globe or have posterior staphyloma. So this can be injured by the needle tap. In those patients, we prefer to do subtenon anesthesia. So this is its advantage, but the disadvantage is that it doesn't provide sufficient akinesia. The peribulbar anesthesia is one of the standard methods for anesthesia. So passing a needle into the peribulbar space, like you are placing the needle into outside the muscle cone and injecting the anesthetic agent. This kind of anesthesia will provide both anesthesia and akinesia. So the patient will not be able or will not feel anything, and also will not be able to move his eyes, which will provide more room for safe surgery. But the problem is that it will also put the patient at risk of certain complications that we are going to discuss now. The retrobulbar anesthesia is the same like peribulbar anesthesia, but we are injecting the anesthetic agent within the muscle cone. So it will also make the patient at more risk of developing local anesthesia complications, and but it has an advantage over the peribulbar, so it will be more rapid duration than the peribulbar. So the peribulbar will be slower in onset than the retrobulbar, but the retrobulbar has more incidence of complications than the peribulbar because you are very close to the optic nerve. You may injure the optic nerve. Finally, the patients will be also another kind of anesthesia. It is general anesthesia. While it is not very common to provide the patients with general anesthesia, but this can sometimes be utilized for specific cases, like for example, traumatic cataract, where the patient has open eye, and we need not to put local anesthesia behind the eye, not to risk extrusion of ocular content and increasing the intraocular pressure. Another indication is that the patient who had a retrobulbar hemorrhage from previous retrobulbar anesthesia. So if this develops like 2 times, we may now think of general anesthesia. Okay, speaking about the complications of anesthesia, what are these complications? First of all, retrobulbar hemorrhage. Retrobulbar hemorrhage can occur in patients who have bleeding tendency, hypertension, or retrobulbar injection of anesthesia. So those patients will show rapidly progressive proptosis with subconjunctival hemorrhage with high intraocular pressure, tense globe with ecchymosis and lid edema, and you will not be able to open the globe. It will be very tight, very tense, and those patients have very high intraocular pressure. So if you didn't recognize that and you just proceeded with the surgery with the sudden opening of the eye causing sudden decompression, rupture of the choroidal blood vessels leading to suprachoroidal hemorrhage. This is one of the devastating complications after cataract surgery, and it is a blinding complication. So maybe in the exam, they will ask you what to do, or this is a very common question in the exam, is what to do if you have a patient with a retrobulbar hemorrhage. So would you do CT scan like that? So you see here a CT scan. Actually, no, this is not the first step. If the first step is to decrease this intraocular pressure to rescue the optic nerve from the compression of the optic nerve. So first of all, you want to guard against this complication. So you should stop the anticoagulants 1 to 2 weeks before the surgery and always opt for peribulbar anesthesia. Doing direct compression will minimize the bleeding, decrease the intraocular pressure by intravenous mannitol and equisuppressants. Here is the lateral canthotomy and cantholisis. This is very important. It's almost asked in every exam in your life, like MCQ exam, like fellowship exam, like Viva and OSCE exam. This is because this is an emergency. So I will tell you how now to do this canthotomy and cantholisis, and then postpone the surgery for 1 week. So this is how to do lateral canthotomy and cantholisis. So this is, again, it's an emergency. First of all, what is the aim of doing lateral canthotomy and cantholisis? It is just to open a space for the blood to be to get out from the orbit in order not to compress over the optic nerve, causing a progressive compressive optic neuropathy. So first of all, you inject anesthetic agent in the skin around the lateral canthus, or together with a decongestant like epinephrine. Then you use you do hemostasis by hemostat. So you're just crushing this lateral canthus area by hemostat in order to crush the blood vessels to minimize the bleeding. Then hold for 30 to 90 seconds. Then by a sharp scissors, you cut the lateral canthus. So this will be the lateral canthotomy. And then you separate the lateral canthal tendon from the orbital rim. And this is what will be called the cantholysis. So lateral canthotomy is cutting the lateral canthus. Lateral cantholysis is releasing the lateral canthal tendon from the orbital rim. We do this by, we cut usually the lower crust of the lateral canthal tendon. So we cut the lower crust of the lateral canthal tendon in order to decompress the globe. Okay, so if this doesn't work, then we can cut the upper crust. This is how would we do the lateral canthotomy and the cantholysis in order to save the patient who had this. This is the retrobulbar hemorrhage or retrobulbar hematoma. Again, this is an emergency. The next serious complication is globe perforation. So for globe perforation, you can, how would you know that the patient had perforation? Usually the patient will experience sudden pain. Then when you examine the globe, you will find hypotony. The globe will be hypotenuse. And when you suspect the patient had globe perforation, you do the fundus examination. So you will find the site of perforation, maybe visible during fundus exam. So you may find the track of the needle, you may find the hemorrhage. which indicates that the presence of fundus globe perforation. So how will you do? What will you do? Postpone the surgery, because if you did the surgery with a hypotenuse globe with perforation, you put the patient at risk of retinal detachment. Then the next day you may, if there is vitreous hemorrhage, then you do ultrasound and just check for the presence of retinal detachment and follow up with the patient till the vitreous hemorrhage subsides, and you will be able to do argon laser retinopexy. Or you can do application of cryopexy or cryotherapy to the globe from outside if the perforation is too peripheral. Finally, the systemic toxicity. So if you have a patient who had accidental intravenous injection, so when you are doing the injection, you should withdraw first in order to make sure that you are not within or inside a blood vessel. But if you didn't do that and you inject accidentally, you will inject the anesthetic agent intravenously. So this will result in that the anesthetic agent will spread to the whole body, resulting in cardiovascular manifestations and CNS manifestations. Those patients could have a tingling, convulsion, or cardiovascular problems such as bradycardia, hypotension, heart failure, cardiac arrest. Why that happens? Because the anesthetic agents will pass through, will reach the brainstem, causing anesthesia of the brainstem, which has its vasomotor center, cardiac center, respiratory center. So this is a very serious complication. So what will be your management? Again, will you order a CT scan or any kind of injection? No, like you see this image. We don't do that. But this is again a serious condition. You need to stop injection. Call for help. This will be the first thing. Then oxygen mask with intravenous Valium, intubation, and the anesthetic doctor will manage the hypotension and cardiac arrest. Usually they inject some antidote intravenous called the Lipidol that will be able to reverse the condition. Optic nerve injury, one of the serious side effects that can happen especially with retrobulbar hemorrhage. And I really cannot see what is the logic behind to send the patient for a CT scan. So you can see that here is the CT scan with the needle inside. It is injured the optic nerve. It could happen. So, but in this case, actually, we don't need to order a CT scan, but maybe this happened to confirm the location of the needle later on. Ocular cardiac reflex, so can happen as well. So, you know, from the physiology that there is attraction or a pressure of the extraocular muscles, or a pressure over the globe can stimulate the vagus nerve, which will stimulate can stimulate the trigeminal nerve, which will stimulate the vagus nerve through the vasovagal reflex or through the ocular cardiac reflex, leading to bradycardia and hypotension. So this is also very important, specifically in strabismus surgery or in children. Extraocular muscle injury is not uncommon following the anesthesia. So you may cause muscle hematoma or contusion with the needle, leading to any kind of strabismus or diplopia. But this will be self-limited and it will resolve by its own. Respiratory arrest, when you are injecting in the intrathecal or in the subarachnoid space of surrounding the optic nerve, leading to that the anesthetic agent will pass into the CSF until it reaches the brainstem, causing brainstem anesthesia. This is again one of the serious complications of local anesthesia. Okay, so watch out for these anesthetic complications. They are very serious. And finally, if you did the all that, you had history, examination, you make your surgical plan, you did the IOL power calculation, you also selected your intraocular lens, you did the anesthesia. Finally, you also need to see if you need any special instruments or special tools before the surgery, depending on the risk that the patient has. Like as we are going to mention later on, if you are not going to need CTR or capsule tension ring if the patient has any kinds of zonular dialysis, or this is for cases of zonular dialysis, but for all cases, you will need to check what is the kind of viscoelastic that you need. So the viscoelastics are these devices used to inflate the globe and can be considered like the surgeon third hand. These are some inert substance, inert material that you inject into the globe, and they have different characters. So what are these kinds of viscoelastic agents? So these are like gel-like material. They will consist of viscous material. These used intraocularly to maintain the space, to preserve the intraocular space, to stabilize tissues, to displace the tissue. So again, it is considered like your third hand. We have two main types of the viscoelastic devices. So it will be either cohesive or the dispersive. What is the difference between both of them? The cohesive tend to have higher molecular weight. So these are having long chain, high molecular weight substance. They have high surface tension. But the dispersive, they disperse, they will spread, they will have low molecular weight and low viscosity. So again, it will be that the dispersive will have lower molecular weight and lower viscosity. The cohesive will have higher molecular weight and high viscosity. So you can consider them like a jam and the honey. Cohesive, you see that this piece of jam, it has high molecular weight. It is very viscous. That's why it is like bulky like that. It doesn't spread easily over surface. While the dispersive, it has it is lower molecular weight with low viscosity. So you can consider it like honey. It can coat, it can spread easily. So we depend on this physical properties of each substance in order to use it for specific functions intraoperatively. So for cohesive, the sense that they have high molecular weight with high viscosity, they will be great for maintaining spaces within the eye. So if you want to create a space, if you want to maintain a space within the eye, then the cohesive will be the option for you. Like, for example, if a patient, you are doing the white cataract surgery and there is intumescent cataract, so cohesive will be the choice. If you are having a small pupil and you want to dilate it, then the cohesive will be of choice. Okay, for the other options or for the other viscoelastic, which is the dispersive, has low viscosity and low molecular weight, so it will be good coatability for protecting the endothelium. It tends to spread easily, so it can protect the endothelium rather than inflate and maintain spaces. So you can do it, or you can put it mainly for protecting the endothelium, like if the patient has endothelial guttates or any endothelial compromise. So you always put dispersive in order to protect the endothelium, as it will spread and coat the endothelium. The other use for the dispersive is when there is rupture posterior capsule and you want to inject a dispersive viscoelastic to coat the anterior vitreous face to prevent disturbance of the anterior hyaloid and prevent vitreous loss. Also, there is another difference between the cohesive and dispersive, that the cohesive is easily removed. You can consider it like it is removed as one piece, like this is a spaghetti. So you can consider it like spaghetti. So it will be easily to be removed in one place, easily removed from the eye. While the dispersive will be harder to remove. Okay, so for some examples, the cohesive will be sodium hyaluronate like Provesc or Helon GV. For the dispersive, some examples are what's called hydroxymethyl propyl cellulose. So this is like what's called Viscoat. Okay, so this will be the differences between the cohesive and the dispersive viscoelastics. I hope that this is clear. There is also a technique that utilizes both kinds of viscoelastics. It's called the Archinov soft shell technique. In the Archinoff soft shell technique, it is a technique to provide protection of the endothelium and also creation and the maintenance of spaces. So we inject both viscoelastics, like we inject dispersive viscoelastics to coat and to protect the core endothelium. And we inject also cohesive viscoelastic to create a space in the anterior chamber, cause more deepening of the anterior chamber, and to flatten the anterior capsule. That will to flatten the anterior capsule so that it will decrease the intralenticular pressure, making the thoraxis more safe. Dr. Elia, can you please repeat the factors that will decrease the PCO? We will come to the PCO at the last slides of the lecture. So there will be a certain slide for the PCO. Just wait for that at the end of the lecture, okay? So this will be discussed in the post-operative complications.